Good morning, everyone, and welcome to this new episode of Clinical Corner from Gise Young. I'm Marco Toselli from Maria Cecilia Hospital, and I'm sorry that my camera is not working, but still I am in good company with Attilio Leone, our young operator from Avellino, and our expert, Prof. Raffaele Piccolo from Federico II University. So the session of the day is about TAVI and the management of coronary artery disease, and we will attend a presentation of a clinical case by Attilio, and then Raffaele will put this case in the context of the notion 3 and comment as well this case. So please feel free to type in the chat any question you may have, and we will try to address during this session. So Attilio, could you please show us the case that you have selected for us?
Good morning, everybody. Thank you, Marco, for the introduction. As you already said, we are going to discuss about the management of coronary artery disease in patients with severe aortic stenosis. Let's go to the clinical case. If I'm able to go, okay. We are talking about a 75-year-old female patient with different comorbidities, including hypertension, chronic obstructive pulmonary disease, chronic kidney disease, obesity. She was admitted to our emergency department for dyspnea and effort angina. The baseline ECG showed sinus rhythm and a pre-existing right bundle branch block. While on baseline echocardiographic evaluation, it revealed reduced ejection fraction of 32% and a severe aortic stenosis with a peak gradient of 78 millimeter mercury and a mean gradient of 48 millimeter mercury. So the patient was admitted to our ward, and first a coronary angiography was carried out. This is the right with diffuse disease without any clear focal stenosis. On the left side, there was an ostial lesion of the circumflex and an additional lesion also of the proximal mid-LAD. So this was the first decision-making point, and we decided to assess the hemodynamic significance of these lesions by invasive physiology. We measured the FFR on both vessels, and it was 0.72 on the LAD and 0.76 on the circumflex. At this time, the procedure was stopped, and then, as we routinely do in these cases, we performed a CT scan from which we had a lot of information. The area of the annulus was 508.9 millimeters squared. The perimeter was 81.9 millimeter. The sinuses were wide enough, at least 31 millimeter each. Coronary height was 23.1 for the right and 13 millimeter for the left. From the vascular side, as you may see, there were diffuse calcification and some tortuosity from both right and left iliofemoral axis, with caliber preserved and suitable for transfemoral TAVI. At this point, we had everything to decide which would have been the best treatment option for this patient, and considering several factors, including age, the extent of the coronary artery disease, the comorbidities such as the reduced ejection fraction, and of course, by calculating syntax score and STS score, we decided to plan PCI of the proximal LAD, PCI of the left main with two-stent technique, and to do a TAVI with a balloon expandable valve in order to take advantage of the easier coronary access if needed in the future. So, from left femoral, we first performed PCI of the proximal mid-LAD with predilation and stent implantation, 3.320 millimeter. And then we did a culotte of the left main bifurcation by implanting a first stent from the left main to the circ, 3.524 millimeter, and the second 3.524 millimeter from the left main to the LAD. Then we optimized the result with a final kissing balloon. And this was the final satisfactory result. Afterward, we obtained our main access, right common femoral artery, by an angio-guided puncture after the placement of a safety wire. We pre-implanted 2 proglides, and after the orthography, we crossed the valve, and we implanted a Edwards Sapien 3 Ultra 26 mm. The result was good, with no significant paravalvular leak or regurgitation, and preserved coronary perfusion. Finally, we achieved closure of the main access with the 2 pre-deployed proglide. And as you can see, there were no vascular complication and no significant bleeding at the puncture site. So the procedure ended after 68 minutes and 240 milliliter contrast administered. The in-hospital stay was uneventful. Patient was discharged after a few days without any further problem. And at 30 days follow-up, the ECG was unchanged. The eGFR and the ejection fraction were slightly improved. The mean gradient was 13, so good result of the TAVI. And the patient was asymptomatic, and she is still currently in good clinical condition. So this is the case, Marco.
Okay, thank you, Attilio. I think it's very common case that we face every day. So a lot of discussing point. I would like to ask to Raffaele, which is the background of your choice and his comment on the strategy you have adopted. So Raffaele, please.
Thank you, Marco. And let me also first say very good morning to all the friends who are connected right now. And also, I would like to express my gratitude to the GISE Young for this very important initiative that is combining actually clinical practice also with a scientific background. And the combination of these 2 factors, I think, are quite relevant now for the management of these patients. That is not anymore probably a case-by-case decision, but it becomes more frequently informed by the available evidence. And I think in 2024, the publication of the results of the Notion 2 trial probably are quite relevant and informative for our clinical practice. As you also touched upon, Marco, this is a very common condition to find out a patient with a severe aortic stenosis and at the same time coronary artery disease. The 2 conditions are frequently intertwined because of the similarities and commonalities of cardiovascular risk factors, but we also do know quite well that both conditions are associated with aging. And therefore, if you look in perspective to the overall registries and trials, if you go to the next one slide, you can see that coronary artery disease is highly represented in patients with severe aortic stenosis, spanning from 15% to more than 80%. There is somehow a stratification according to the underlying risk profile of patients. High risk, inoperable, and intermediate risk patients have an increased prevalence of coronary artery disease in view of their older age. In patients low risk, there is still a presence of coronary artery disease, but the problem is not the prevalence of the condition, but the incidence of coronary artery disease over time, because these are patients younger and therefore have more a life perspective and therefore high probability to develop in the future CAD. So CAD may become or a problem in the future, a longitudinal problem, or is frequently a problem in patients with a greater risk profile like the one that Attilio just showed us. Now, if we also go to the next slide, we can see that there is actually some challenges in the definition of coronary artery disease in patients undergoing TAVI. We have heterogeneity in terms of coronary artery disease definition across the studies. And then there is also next one, also another point that patients with the severe coronary artery disease, so for example, patients with very high syntax score were excluded from major trials. So this is a field that probably we do not have much evidence. Now, I think that it's quite clear that the combination of the two aspects, so the coronary artery disease and aortic stenosis, confer an increased risk of cardiovascular events over time, as you can clearly see here in this propensity age and gender matched study that we did some years ago. And then probably among patients with the coronary artery disease, next one, if you look to the subset of patients with the high syntax score, this is probably a clear subgroup of patients having the highest risk of events over time. Now, comes the next one, I would say like the status quo. So which is the recommendation from ESC guidelines in terms of coronary artery disease management in patients undergoing TAVI. Well, as you can clearly see from this recommendation, the class and the level of recommendation in 2021 guidelines was quite low. So we had very limited evidence, which, however, was summarized in this recommendation, indicating PCI in patients with the stenosis more than 70% in the proximal segments of the epicardial territory. Now, if you go again to the another one slide, we have now the Notion 2-3 trial, which actually came out in ESC this year, just a few months ago. This is probably a landmark trial with more than 400 patients with aortic stenosis undergoing TAVI. You can see that the median age was 82 years. This was a low-risk population. In terms of STS score was 3. The median follow-up was not very high, 2 years, but you can see the Kaplan-Meier curves arrived to a 5-year follow-up. And also let's try to focus about the patient characteristics that I think are quite relevant in the interpretation of the trial results. So patients had the median syntax score of 9, and probably the patient that we have just seen is probably not very representative of this case, but on average 9 of syntax score is something that we probably see in the field, for example, of STEMI patients undergoing primary PCI. This is the kind of coronary artery disease complexity. Now, when TAVI was performed, in most of cases before TAVI, 74%, 17% of patients underwent concomitant TAVI and PCI. We are talking about the arm of patients randomized to PCI. The control arm was the subgroup of patients randomized to optimal medical therapy. And then in less than 10% of patients, PCI was performed after TAVI. Now, I think that the case that we have just seen was a concomitant PCI and TAVI, if I correctly understood. So this has to be taken into account, and probably, I mean, the center is well known for having very expert operators, so they can probably well manage the complexity of coronary artery disease and TAVI at the same time in the single session. And if you look also here, 40% of patients received the balloon expandable prosthesis. Now, if we turn to the right of the slide, you can see the primary endpoint of the trial, which was a composite of all-cause death MI and urgent revascularization. Patients randomized to PCI had a lower risk with the 29% relative risk decrease of the primary endpoint in comparison to those randomized to conservative treatment. Next one, you can here see the components of the primary endpoint. Actually, this benefit was not driven by all-cause death, because there was actually no difference between the two groups. We had a remarkable decrease in the risk of myocardial infarction and urgent revascularization. And actually, we know that the two endpoints are quite connected. The reduction of MI was 46% relative risk reduction, and 80% was the relative risk reduction for urgent revascularization. So very high benefit. But here, I think that I would like you to focus on a single aspect of these survival curves. If you focus on the endpoint of MI, you will clearly see that during the first year after PCI, there was no difference in terms of MI between the two groups. And similarly, the risk of all-cause death was very superimposable, at least for the first 3 years of follow-up. Now, keep in mind this data. We will come back in a second. And then if we look to the subgroup analysis, I think it's also worth mentioning that the benefit in terms of primary endpoint was more concentrated in the subgroup of patients with a diameter stenosis estimated more than 90%. I just forgot to also mention that the two key criteria for performing PCI was either an FFR of 0.80, which was like the case we've just seen, or you could also use angiography, and in this case, the estimated severity had to be more than 90%. So I think that the combination of the two techniques are also quite informative for the application in our clinical practice in order to, put in also in practice the results of the Notion 3 trial. Now, if you go to the next slide, I think that if we look to in a broader perspective, the data from the Notion 3 trial, I think that when I just read the paper, these results remind me another trial, the ischemia trial, which had a similar, I would say, approach. Patients were randomized to revascularization, which in most of cases was done by PCI or optimal medical therapy. The only difference was the presence and absence of aortic stenosis and TAVI in one group, and the lack of this in the group of patients randomized in the ischemia trial. Again, if you look to the overall strategy, there was no difference in the 5-year follow-up. However, if you look to the right part of the slide, you can see that there is some benefit accumulating over time. It's important also to go to the next slide and appreciate the difference in terms of the CV death, MI, and CV death and myocardial infarction. Now, if you look to CV death, there was actually no difference. If we look to the MI, there was a crisscross of the two curves, and if you go to, again, the next slide, the crisscross means a violation of the proportional hazard assumption, which means that we have a kind of risk in the first period of the follow-up, and then another risk in the late follow-up. This was due to a high risk of periprocedural MI in patients randomized to invasive strategy, and a lower risk of type 1 MI, so spontaneous event during the late follow-up. Therefore, this is quite consistent with the result we have just seen from the Notion 3 trial, because the risk of MI was actually also reduced in the ischemia trial. If you go to the next slide, I think that how we can put all these data in perspective. So revascularization is probably important in patients undergoing TAVI, but it is important in order to prevent the MI-related events, which are actually the natural history of untreated coronary artery disease. But probably it's not relevant for the TAVI procedure itself. If you look to the Kaplan-Meier curves, there was actually no hazard of performing TAVI without PCI during the first year. And if you look also to this very recent data from a Cleveland clinic, you can also see here that if you look to the previous one, sorry, yes, this one. If you look here in this study, if you look to the broad and the kind of spectrum of coronary artery disease from the non-obstructive to the extreme, the procedural complications were not different from patients with extreme versus non-obstructive coronary artery disease. So this is probably something that we need to keep in the context also of the NOTION-T trial. And coming back again to the next one slide. Yes, this one, I think that the valve choice was very correct. We know that, you know, there is this issue with reaccess in patients undergoing self-expanding valve implantation. This is probably not quite relevant for you know, the balloon expandable valve. In this case, the SAPIEN 3 Ultra has also improved the area of the open cell. So this is probably quite relevant for coronary recannulation. Go to again next one, which I think again is probably important here. If you look that you know, with the self-expandable valve, you may have actually a lower probability of selective recannulation, which is important in the context of the you know, follow-up of these patients. But actually, the coronary cannulation with the balloon expandable is not very relevant. So I think that the case was very well managed. And I think also probably anticipated, I don't know if it was performed before or after the publication of the NOTION-T trial, but in a way was quite in line with the contemporary management, I think, of coronary artery disease in view of the, you know, the NOTION-T trial. Thank you.
Thank you Raffaele. Thank you for this topic overview, very precise and important, a lot of key messages. We have a couple of questions coming from the chat. I would start asking to you what's your approach and what you think about performing physiology in the setting of aortic stenosis. We know that NOTION used FFR. So in this setting, to discriminate which coronary artery disease has to treat. So do you think this is a good way to proceed?
I think that, I mean, I'm not very fond of physiology, but I think it's a very relevant option. The trial added the possibility to include patients with, you know, with the severe stenosis or positive FFR. I think that the data that we have now is probably that the management of coronary artery disease has nothing to do with the TAVI. So the improvement that we can have by treating with the PCI coronary artery disease in the setting of TAVI is very close to the same benefit and also the harm that we can have in patients with stable coronary artery disease. So I think that if used in the context of coronary artery disease, FFR is okay, especially in the case of stenosis that are not very angiographically severe. Probably we have some data for the, which index is best for the issue of underlying severe aortic stenosis. We know that resting index may have some limitation in the context of functional assessment. So probably this may be a kind of difference between TAVI versus non-TAVI. But again, I think that both approaches are quite reasonable.
Thank you. And so back to the case of Attilio. Maybe Attilio, you can take this one. So you decide to perform the PCI during the procedure. Can you please justify why you have done this approach, and also considering that you have a left main procedure with two-stent technique, so during having aortic stenosis, and probably some of the audience would treat before the valve and then do the PCI.
Yes, of course, that would have been an option. What we did basically was we carried out the coronary angiography, then we stopped, because when there is still room for discussion, we do this way. We do first coronary angiography, then we stop, we discuss, and then if there is PCI to do, we do in the same context of the TAVI. I know it was a complex procedure. That was the reason why we chose left femoral access as an auxiliary access, because we usually do from left radial. But we were quite confident that before TAVI, the patient was stable, so we could do PCI, as Raffaele said, before the valve implantation, and then we implanted a balloon expandable valve in a easy way, and so in 68 minutes the procedure was ended.
Perfect. So we are just on time. So I would ask to Raffaele if you can provide us some take-home messages for about this session, about what we learned, also about the Attilio case.
Yeah, sure. So I think that TAVI CAD we can summarize in 3 key points. The first one is that coronary artery disease is highly prevalent in patients undergoing TAVI, especially in patients with intermediate and high risk, and carries a poor prognosis. Now, management of TAVI in TAVI patients, I think that PCI certainly may be a beneficial option, but not for the success of the TAVI procedure itself, but I think for the CAD-related adverse outcomes. Coronary reaccess is certainly also an issue to have at the horizon in patients also without coronary artery disease when we perform TAVI with very good life expectancy, and is certainly a problem in patients with coronary artery disease at the time of PCI, because there is certainly not very high, but there is quite clear higher risk of unplanned PCI, and this risk is particularly higher in patients with multivessel coronary artery disease, like the one that Attilio showed us this morning.
Oh, fantastic. So really a good way to close. So it was a very informative session about the management of coronary artery disease in TAVI candidates. So thank you to Attilio for your case, and Raffaele for all your insight. And so I would we will wait you at we will see you at GISE Congress. We will have some Gise Young session early in the morning at 8, but in the main arena, so will be a chance to meet you and discuss about clinical case. So again, thank you, and see you in the next episode at the Congress. Thank you.
Thank you. Bye. Good morning.
Bye bye.
Nice day. Bye.